This meeting is being recorded.
Hi, everyone. I see all of you are starting to join. We'll get started in just a minute or two once we have everyone with us. Thanks so much. Okay, I think we're going to go ahead and get started. My name is Harpreet Paul, and I'm the Academic Chair of Pediatrics at Hackensack Meridian School of Medicine and also Chair of Pediatrics at K. Hovnanian Children's Hospital at Jersey Shore University Medical Center. Thank you so much for attending our event today. What an amazing topic. It's an incredible session that you're going to have with our speakers today. The speakers you're going to be hearing from are the top neurosurgeons, pediatric neurosurgeons, and epileptologists in their field. They're going to host a discussion to understanding all types of epilepsy, and the updates that you're going to hear about are the cutting-edge surgical options that are offering potentially life-changing cures in some patients. This is one of the most commonly requested topics for our lunch series, so we're really happy to have the opportunity to partner with the NJAAP to share our experts' opinions. Special thanks to our speakers, Drs. Lawrence Daniels, Luke Tomix, Eric Segal, and Raj Sachdeo. And of course, thanks to all of you who've taken time out from your busy schedules to attend our discussion today. You're all going to be in for an exceptional treat. This session is going to be recorded, and you're going to be getting the link to the recording following the presentation. So with that, I'm going to be turning it over to our first speaker, Dr. Sachdeo.
Thank you, Dr. Paul. What I'd like to do is, on my first slide, try to separate what a seizure is and epilepsy. Seizure is just a transient, reversible behavior alteration due to excessive neuronal discharge. 9 to 10% of the population will have at least one seizure in their lifetime. Epilepsy, however, is 2 or more unprovoked seizures. There are exceptions if you have one unprovoked seizure with abnormal EEG or abnormal MRI. You can have higher than 60% chance of having a seizure in the future, so we make the diagnosis of epilepsy. If you have a provoked seizure like hyperventilation or photic stimulation and your EEG has correspondent abnormality, you are diagnosed as epileptic. Now, how do we make epileptic syndromes? When you have combination of certain seizure types, EEG abnormality and MRI or imaging abnormalities, it becomes like a syndrome Example is West syndrome, where you have infantile spasms with hypsarrhythmia pattern on the EEG and invariably normal MRI. Next slide. Now, if you look at the simple mechanism of a seizure, the brain is very well balanced between inhibition and excitation. Slight imbalance, either decrease in inhibition or increase in excitation, is what causes the seizure. Next slide. Almost 3.5 million people in US are diagnosed with epilepsy. Children carry the highest burden. 3 to 5% of children have epilepsy. And even though the total population, it's less than 1% has epilepsy, 60% of all seizures, they start in childhood. And if you look at this graph, you'll see that the biggest chunk of seizures occur either before the age of 5 or after the age of 65. Next slide. Now, what we know about the baby's brain is they like to have seizures. And seizures so often are the first neurological dysfunction of the neonate. It's one of the strongest predictor of the mortality and mortality in these children. There are various types of seizures that babies have. If I could have the next slide. You can have very subtle activities like blinking, nystagmus, pedaling movements. However, if you have decerebrate or decorticate posturing, which we invariably see in children with intracranial hemorrhage or severely compromised brains, the prognosis tend to be not very good. Next slide, please. The cause of neonatal seizures, a third of them is hypoxic ischemic encephalopathy. Intracranial hemorrhage, infarction are also high up on the list. Inborn errors, metabolic disorders tend to be much lower. One of the things I definitely would like to point out here is pyridoxine deficiency. It's a treatable cause. You have neonate with seizures, it's always worth giving and seeing if the child responds, the seizures respond to pyridoxine. Next slide. Apart from severe neonatal epilepsy, you have several benign seizures that you see in children, neonates. Benign sleep myoclonus of infancy tend to occur before the age of 6. These kids don't need anti-seizure medications. It resolves by itself. Next slide. You have idiopathic neonatal seizures. It was commonly called as the 5th day fits. It happens anywhere from day 1 to day 7. You have more often chronic focal epilepsy. EEGs are normal. They resolve without any neurological deficits. Next slide. You have benign familial neonatal seizures. These are secondary to potassium channelopathy. They also resolve completely and invariably don't need to be on anti-seizure medications for a long time, period. Next slide. Now, febrile seizures are seen more common. They occur anywhere from age 6 to 5 years. The seizure, if they happen before the age of 1 or after the age of 3, tend to have higher risk of the child developing real epilepsy. We divide febrile seizures into simple or complex. If the child has a single seizure, less than 15 minutes, it's a simple seizure, febrile seizure. However, if the seizure is prolonged or they have it more than 2 times in 24 hours, or they have seizure lasting more than 30 minutes, they fall in complex febrile seizure. Next slide. So often parents will ask the question, will my child have epilepsy? The children who've had febrile seizures. The simple thing is, if the seizure Was single seizure lasted less than 15 minutes? Very unlikely. If the seizure lasted more than 15 minutes and happens more than twice in 24 hours, or if the child has status lasting more than 30 minutes a seizure, or if there's a strong family history of seizures, the chances are high, almost 5%, that these febrile seizure kids may develop real epilepsy. Next slide. Infantile spasm is something which tends to be horrific. You see it anywhere between the age of 2 months to 3 years, but more often around the age of 6 months. Seen slightly more often in males than females. 30% of the infantile spasm patients, we do not have an etiology. And almost 50% of the patients in those where we don't have an etiology have very good prognosis. They tend to resolve or literally stop having seizures and develop perfectly normally. On the flip side, if the patient has Down syndrome or CDKL mutation or inborn errors of metabolism, they tend not to have very good prognosis. Next slide. Childhood absence, you see it in almost 15% of seizures in childhood. They occur between the age of 4 and 10. Very rarely after the age of 11. They tend to get worse during puberty, and we see it more often in females than males. Usually by the age of 14, 15, the seizures resolve and the children can be taken off the anti-seizure medication. Next slide. Benign Rolandic epilepsy or benign epileptic activities from central temporal region are another very common type of seizures. You see it in children between the age of 4 and 11. Peak is around 8. Most of these seizures occur when the child is going to sleep or early hours of awakening. They tend to have oral facial numbness, tingling, and invariably it will involve either the facial tic or a one-hand tic. They respond very well to anti-seizure medication, and majority of them, the seizures resolve by the time they are 15, 16 years old. Next slide. Pancytopolous syndrome or childhood occipital epileptiform activity. This is relatively uncommon, occurs any time between the age of 1 and 14 years. The peak is around 3 to 6. So often these patients used to be labeled as psychogenic or pseudo seizures because the child can hear things, they can talk to you during these episodes. They may have nystagmoid movement. They more often will have visual field changes with colorful, bright objects, severe nausea and vomiting, more of autonomic symptoms. The prognosis of this type of seizures is very good. Majority of them, the seizures resolve before the age of 18, and these children do not need to be on anti-seizure medication. Since the seizures occur so uncommon, maybe 3 or 4 times in a year, several of us don't even like to put them on regular anti-seizure medication. What we do is put them on rescue medicine. So whenever they have it, since a seizure can last up to an hour, to use that to stop the seizure. Next slide, please. Lennox-Gastaut syndrome tends to happen in fairly high percentage of children with infantile spasm. The tetrad we use for them is developmental delay, multiple seizure types. The hallmark of the seizure is tonic seizures, and invariably they also have atonic and myoclonic seizures. And the EEG is normally severely abnormal with 1.5 to 2 hertz spike and wave activity. In the past, the treatment was very difficult. Over the last 20 years, things have improved. Next slide. Now, the takeaway message, if I could do it in a few words, is once you diagnose seizures, be very aggressive in treating. Keep in mind, seizures beget seizures. The more seizures a child have, keep in mind, the brain is the site of learning. It learns the bad behavior and has more seizures. You want to make sure that you treat them with appropriate anti-seizure medication, appropriate dosage, and encourage the families about sleep hygiene. Avoid medications like Benadryl, Tramadol, stimulants, which can precipitate seizures. Also, keep adjusting the anti-seizure medication with age and weight. And if the child is having therapeutic resistant seizures, think of differential. Does he really have seizures? Is it migraine, sleep disorder? Is the pathology progressive? Or the child, especially teenagers, have psychogenic seizures? I think I'm going to stop here and hand over the mic to Dr. Daniels.
Okay.
Dr. Segal.
No problem. No problem. Hi. That was actually a really good talk, and I think a great place to start. We're going to talk about medication-resistant epilepsy management. So the idea here is that Dr. Sachideo kind of walked us through what is the definition of epilepsy, different epilepsy syndromes, but what to think about when medications are not working. And so when medications don't work, then we have a host of non-pharmacologic therapies as well that we can offer. But I think what probably makes the most sense in this conference is to start by talking about where we are with medications. And so we have a better understanding about medication-resistant epilepsy, how common is it, and then what do we do once we find that a patient has medication-resistant epilepsy. So, when we have a patient who comes in for the first visit, we really break up the entire visit into two parallel paths. One is from a diagnostic perspective and the other is from a therapeutic perspective. With the diagnostics, we are looking at different ways of studying the brain. We don't have a perfect test for the brain. And so we will look at structural challenges or problems through neuroimaging. We will look at functional studies such as electroencephalogram as well. For patients in certain circumstances, especially for those who seems to have a non-acquired epilepsy, we will do genetic testing and neuropsychological testing, because to be clear, it's not just seizures is the problem, right? So when patients with epilepsy, they're presenting to us because of seizures, but that's really a symptom of an underlying neurological problem that can affect cognition as well as behavior. From a therapeutic perspective, we really break that down into, like any chronic condition, prophylactic and abortive therapies, of which fortunately there are a lot of now. And we definitely want to talk about SUDEP. For those of you who are not familiar with it, SUDEP is sudden unexplained death in epilepsy patients. It affects about 1 in 1,000 patients. It's roughly the same frequency as we see with SIDS. And the patients who are at greatest risk for it are patients who have uncontrolled seizures, convulsive, typically in their sleep, convulsive and typically in their sleep. So those three factors. And there are different techniques that we have involved to try to prevent SUDEP, and we try to bring up SUDEP early on in our visits because we want to make sure everyone's aware of them so we can prevent this. And then finally, seizure restrictions. And seizure restrictions has to do with daily life. It has to do with athletic activities as well. And then also has to do with driving, which comes up for our adolescent patients. And then lastly, we talk about outcomes. What is the natural history of the epilepsy? And that's when we dive into talking about medication-resistant epilepsy, because that is a potential outcome. Sometimes patients are doing just fine with one seizure medication, other times they don't. And so that's when we bring up the topic of medication-resistant epilepsy. And that's really all in the first visit. So this is a slide that keeps on changing because there are more and more medications that are coming out onto the market for patients with epilepsy. So as you can see on the far left of your screen, there was very little available bromides, and then barbiturates such as phenobarbital, and then there was a breakthrough discovery with phenytoin, and that led into the first generation of anti-seizure medications up until about 1980, 81 with valproic acid, and then you see the second and third generation anti-seizure medications. Despite the fact that we have so many anti-seizure medications, I think the challenge is that, or the question that one could ask is, are we better off because of that? Do we have better seizure control because of that? And the answer is not clear that that's correct. You know, we definitely have better side effects. That's true. So the side effect profiles have improved dramatically over the past 20 years. But the actual control of seizures with anti-seizure medications, it's not clear if it's had a meaningful benefit or marginal. Definitely, there's been some outstanding medications such as felbamate and valproic acid, but a lot of these medications, they're very similar in terms of the different channels that they work on the neuron up until recently. Recently, we've had some interesting therapies such as cannabidiol, which we do employ, cenobamate, which has been very effective. But a lot of these other therapies are somewhat similar, have a different side effect profile, and we find ourselves in some ways not as much better off as we'd like to be from a pharmacotherapeutic perspective than we were a few decades ago. And this, drives home the point. There's a lot happening on the slide, and I know a little bit is blurry, but I think the relevant pieces can be seen quite clearly. So if you just look at the colorful slide in the center, this is shows you prescribing practices for anti-seizure medications. So the green here is the carbamazepine, and you can see Tegretol, received a lot of prescriptions in the early 1980s, then fell off, and valproic acid picked up those prescriptions and has fallen off. And then this dotted line here that you can see is when we started developing the second generation medications, and we prescribed, let's say, a lot of levetiracetam, a lot of Keppra, and then some of our older seizure medications have fallen off in terms of prescriptions, and our newer medications, like here, this is levetiracetam or lamotrigine, have picked up. And so the original, in 2002, there was a 14-year cohort published by Kwan and Brody that demonstrated that about 30% of adults had inadequate control with seizure medications, right? So what we're saying here is that despite the fact that they're taking multiple anti-seizure medications, about 30% of them still have breakthrough seizures. Now, fast forward into 2018, and in the 2018 study, we're actually not that much better than we were back in the 2002 paper. So about 64% of patients were seizure-free for 1 year. And if a patient doesn't respond to the first anti-seizure medication, they have a 1.73 times greater risk of having resistant epilepsy if that first medication fails. And so in these studies, we can see here that there's increases in probability of 1 year seizure freedom and with anti-epileptics. But you can see that as we go from the first, second, and third medications, the differences between the light blue and the dark blue decreases, and there becomes less and less of a chance of achieving that seizure freedom that we want for our patients and that they deserve. So put this in a different way, for patients who are patients who come to the adult clinic, and we extrapolate this for pediatrics as well, when we start them on the first anti-seizure medication, the chance of seizure freedom, 0 seizures, is about 46%. Now, if that first anti-seizure medication doesn't work, and we have to, at good doses, with good compliance, and we have to go to a second anti-seizure medication, the chance of seizure freedom drops to about 12%. Now, if the second anti-seizure medication doesn't work, then the chance of seizure freedom from there is less than 5%. So the International League Against Epilepsy defines a medication-resistant or drug-resistant epilepsy as a failure of 2 appropriately chosen and tolerated anti-seizure medications. Doesn't matter if it's in combination or by itself as a monotherapy. So after 2 drug failures, seizure freedom rates with subsequent anti-seizure medication trials are dramatically decreased. So this is how we begin our visit, because we want to make patients aware that about a third of patients with epilepsy have a drug-resistant epilepsy. You can see about 36% here. And that's not meant to make a person feel resigned to their fate, or that things are not going to go well for them. Rather, it's an opportunity to start talking about other options as well. And those other options include diet therapy, marijuana-based therapies, neurostimulators, clinical trials, and epilepsy surgery. And of all that suite of options, we still work with seizure medications. We'll try different combinations. But of the suite of options, what has, for the right candidate, for the right patient, really epilepsy surgery has the highest chance of achieving seizure freedom. We don't really get seizure freedom with a lot of those other therapies that I've discussed. It's really epilepsy surgery for the right person. Okay, so I just went through this, right? So again, the non-pharmacologic therapies that we start talking about include cannabis, which is now more conventional than it was a few years ago, diet therapy, and we run diet therapy clinics through the Hackensack Meridian health system, and that includes ketogenic diet, modified Atkins diet, low glycemic index treatment. We talk about neurostimulation, and neurostimulation could be either intracranial neurostimulation or extracranial neurostimulation. Resective surgery, including more minimally invasive techniques that will be discussed a little bit later, like laser ablation, and clinical trials. So we have, there are new therapies with completely different mechanisms of action that are not yet commercially available. And this is something that we want to give to our patients to hopefully give them hope that there may be something good around the corner as well. And we've had some pretty amazing breakthroughs in the past 12 years that I've been doing this, and for others who've been doing it for longer. And so there's always hope that we're going to have a new and better therapies around the corner. So the first item that I mentioned was surgery. Now, when surgery is being considered, we have there's been shifts in thinking in terms of how to plan a surgery, which patient is the right surgical candidate, what does success mean of an epilepsy surgery. Now, some of these topics are going to be discussed by Dr. Daniels and Dr. Tomich, so I'm not going to dive too much into them because I know that they're going to go into greater depth. So what I'll mention to start with is that we used to just only look at the EEG and the semiology of the seizure. So semiology means, what does a seizure look like? Do they start with a funny taste in their mouth? Is there hyperkinetic movements? Are there visual phenomena? So we use that in the EEG to plan a surgery. But now we do way more than that. So we look for functional clues and electrical clues, like I mentioned with EEG and semiology. We have better ways of understanding the structure and metabolism. And so we may move from just a structural lesion in the small circle here to understand a greater network that's involved here for the patient's epilepsy. This is a busy slide and we're not going to get into too much depth, and Dr. Daniels, I think, is going to dive into a lot more of this. But this is just to show you this kind of Swiss cheese approach that we're taking for patients with epilepsy, where we don't just rely on one particular modality. So the functional clues, like I mentioned a moment ago, is the seizure semiology. What does it look like? Any neurological testing, including neurophysiological testing. And sometimes on an invasive side, we'll actually try to stimulate seizures themselves for patients who have invasive electrodes. We'll look at electrical abnormalities such as the EEG, a magnetoelectroencephalogram, the MEG scans, as well as functional MRIs. And then more invasively, down on the bottom here, we may use some minimally invasive techniques such as stereo EEG or electrocardiography, as well as what you'll see later is electrical grids and strips. From a structural perspective, I mentioned already the MRI. Some people will use diffusion tensor imaging, which is an MRI technique. And then down on the more invasive, the intraoperative, there are also intraoperative MRIs that we now have access to that has really changed and been a paradigm shift in terms of some of the minimally invasive techniques we're able to offer. And then finally, on a metabolic perspective, We use PET scans and SPECT scans to better understand the metabolism of the brain and to help identify seizure foci and their networks. And then lastly, we can use that metabolic testing as well for optical mapping, which is more of on the research end than clinically available, but it's something that we're following closely. This is a very blurry slide, and it's meant to be that intentionally, just to go through with you all the different types of non-invasive testing that we consider for our patients. So the epileptologist guides the pre-surgical pathway and to figure out who needs what test based on the cause of their epilepsy, based on the examination, based on their hand dominance, which tells us maybe where their language dominance is. And we will use all of that clinical information and also what the goals are for the families and the patients to pick which is the next best test to use. What it really looks like is this, which is very complex. And each patient is different. And this is a little bit more of where the art and the science meet each other. And then once we're able to complete all of this non-invasive testing, neuropsychological evaluations, we may do functional MRIs to see where language is coming from, the EEGs, the MRIs, the MEG scans, the SPECT scans, and the PET scans. Then we package it up together and bring it to the Epilepsy Surgical Conference that Dr. Daniels will be talking about next. These are different ways that we have thought about seizure networks and seizures and different surgical strategies that we have considered. But what we start with is this conceptual zones here, and we think about the interplay between the healthy brain tissue as well as the diseased tissue to better identify where the networks are and what parts of the brain may be involved after a seizure kicks off. And then we use these current diagnostics, as I mentioned, that Swiss cheese approach, using the ictal EEG, which is the EEG that shows the seizures, the SPECTs, the MRIs, and everything else here, to create a surgical strategy here as to which is the primary zone that we're interested in, and perhaps where are the network that's involved, so we can either goalpost or find the exact area of interest to make sure that we are able to offer patients the highest chance for seizure freedom. Okay, thank you.
Thank you. That was, man, I just want to stop and say this is an outstanding group of presentations so far. Happy to be a part of it. So my name is Dr. Lawrence Daniels. I'm a pediatric neurosurgeon. And, you know, I think that what I'm going to do is be a little bit more philosophical with my talk, because we've gotten some really, really good technical talks. And what I want to do is talk about the Epilepsy Surgery Conference. And I want to use an analogy that's really close to my heart, because my wife's an internist and she's constantly reminding me that in the grand scheme of things, I'm not really very important as a neurosurgeon, right? If anyone has a problem in a family, they go to her. You know, anytime any of her patients need to see a specialist, she's the type of internist, a primary care doctor, where she makes sure she's involved and she understands. And watching her practice has kind of given me a concept of an internist like the parental guardian of medicine, right? And all the pediatricians and all the primary care doctors for the babies, that's the way that I view you. You're like the parental guardians of your patients. And oftentimes to consider, you know, doing a surgery on brain that grossly appears normal, there's a reflex to that. There's a hesitation to that. I mean, myself as a surgeon, when we train as surgeons, we train to take out tumors or we train to take out infections. But there's a certain type of feeling you get when you're taking out brain that's not grossly pathological. There's a hesitation and resistance to that. And I think that's a healthy resistance and hesitation. And what I want to describe the Epilepsy Surgery Conference as is almost a stopgap, right? A measure that's used in order to have multiple different specialists get involved in making the decision, selecting candidates, and then interrogating whether these candidates are truly surgical candidates or not, for the protection of the patient, right? To make sure we fully vet the risk and benefit of potentially intervening and exposing someone to the risk of epilepsy surgery in their brain. So next slide. So the title says a lot for us, right? It's the Epilepsy Surgical Conference. It is the search of an epileptic focus but it's also the investigation of a surgical candidate. And these are essentially the goals of Epilepsy Conference. Next slide. What we will discuss briefly is who makes up Epilepsy Conference, which is a multidisciplinary team, why we gather in the conference format, which is to find and to search for and find an epilepsy focus. Sometimes that's already been obtained by the epileptologist, but then also to determine whether a patient is a surgical candidate, meaning to determine whether the pathology would be responsive to surgical treatment. But in addition to that, and I think this is the most important part, and this is what I enjoy most about the conference, it's also to interrogate the recommendations themselves of the option of surgery. And like many multidisciplinary conferences, we all get together, we roll up our sleeves, we duke it out behind closed doors. We are free to express our opinions. And at the end of that, we come up with a consensus on what we think is best for that patient. And then the next step is then for a provider to take that patient to the patient, educate them on what was discussed, give them the freedom then to make their own decision as to which path they want to go down. And the last thing is, how do we do this? And we do this by analyzing a lot of data. I really appreciate the slide that Dr. Segal just showed. It is a complex process of analyzing a lot of historical data, which we'll discuss, and also objective data that we acquire through non-invasive and invasive means to give us electrical information on the nature of the seizures, where they start and where they travel. Next slide. So this slide here is supposed to depict the members of the team, but the reason why I've organized this slide in this manner is because the epileptologist is the king, right? The epileptologist is the person that has been treating these patients and dealing with these patients, and oftentimes is the person that's bringing the patient to the conference, right? We also have the EEG techs that are involved in the conference as well, because they're the ones that are doing the manual mechanical work of putting the leads on the patients, understanding what might be artifact, what might not be artifact, and helping us interpret, read, show this real-time data on a patient, correlate that with the data's the patient's clinical presentation and semiology, right? And then assisting us in interpreting that data and presenting that data during conference. The pediatricians or the primary care doctors, oftentimes epilepsy conferences have a pediatrician there because remember, primary care doctors are extremely important in this entire process, and I view them as the parental guardians. And their role is to make sure that we're informed about the entire patient and not just the pathology that we're there to discuss. Social workers become a really important component of an epilepsy surgery conference because all patients are not created equal. These disease processes do not occur in social vacuums, and patients' resources that they have available to them in their community and their home becomes a really, really important component in deciding whether we're going to expose somebody to a surgical treatment that requires a significant amount of after surgery care in order for the surgery to be successful, in order to make the surgery risk appropriate. The neuroradiologists obviously are there to help us at times glean certain information from the imaging studies that we obtain, some of the non-invasive data that we obtain from these patients, and also to assist us in recommending what other type of imaging studies might be available for patients. The neuropsychologists are important to give us an idea, to dig a little bit deeper than what's obvious from a clinical perspective. They can give us an idea of how these seizures might be impacting a patient's cognition, cognitive findings that are not obvious to a gross neurological exam. They also are very helpful in delineating eloquent area for us. Oftentimes when patients have seizures when they're young, they reorganize their brains. And as a result of that, we can't take for granted that their motor cortex or their speech area is located in the area that the textbooks tell us it's located, right? Oftentimes there's additional work that we have to do in order to identify and localize whether some of these functions are being impacted by the seizure. And then at the bottom, there are people like me, right? Surgeons, although it's called it's called Epilepsy Surgical Conference. Really, the surgeons are probably the last people to weigh in on whether it's appropriate or not to do a surgical intervention. And we offer our experience on the outcomes of these surgeries, the difficulty of these surgeries, and the risk that the patient might be exposed to. Next slide. So now behind all of this is the why. Why are we there? We're there to search and to find an epilepsy focus. This is a slide similar to a slide that has been presented before that gives us a concept on how we think about epilepsy, right? So the first circle without the lines is considered the first order of onset, right? This might be where a seizure starts, but then that second circle without the lines is where that seizure or abnormal electrical activity might immediately spread. And then it might spread to a third order portion, sometimes the opposite side of the brain. And with our traditional means, or the most common means of measuring seizure activity, this spread, which occurs electrically, might occur so quickly that it's difficult for us to understand exactly this pattern. Next slide. When you take into consideration that the electrical activity for the brain begins to travel on some of these super highways, the white fiber tracks that communicate one part of the brain to the next. And what this slide is designed to illustrate is the extent of these white fiber tracks. So imagine a seizure starting in one location and then rapidly through the spread of an electrical current spreading to other different parts of the brain and even the different sides of the brain. Go to the next slide. You can see that a seizure that might start in one location can spread to completely different other locations. And in some ways, this is almost like a fingerprint. It can be unique to almost every single patient. What we are attempting to do in not only localizing this focus, but then also understanding how this seizure traveled to other parts of the brain and how this affects the patient is we're attempting to develop what we call a seizure hypothesis. We're attempting to get an understanding of not only where the seizures start, but the networks that are affected by the seizure in an attempt to try to plan a means to disrupt this. And if we can disrupt this process, we might be able to either eliminate the seizures altogether or the limit to seizures to areas that don't have the same type of long-term impact to the brain, especially in younger patients with a developing brain. Next slide. So how do we do this? Well, we collect data. A lot of this data is already collected. Right? Every patient that comes to an epilepsy conference comes with a history of seizure activity and an attempt to treat that seizure activity, right? The patients that we typically see in our conferences are patients that were concerned that medical therapy is not effective enough. It's not working and they might be refractory. So the first thing that we do is we present a case report of the patient that goes over the patient's history, which involve their seizure onset, the first time they had a seizure, EEG data that they have accumulated in the past. And sometimes you have patients that have had seizures for a long period of time, and you can map out the change in that EEG data and study the evolution of that seizure. Dr. Sachideo said something that was really, really important. And part of the reason why we're having this conversation is because we know in our communities, there are a lot of patients who have seizures that are not being treated optimally, that are not getting the consideration they deserve, either for additional medications or for additional therapies. And we know as long as these patients are having seizures, that disruption to that part of the brain can spread to other parts of the brain, which ultimately makes it more difficult to treat. There's also a conversation of the medical history of these seizures as well. And then physical examination, right? So what type of neurological findings that we detect when we examine the patient, whether there are weakness in certain areas, whether there are changes in their cognitive ability, and also the seizure semiology. When someone has this random electrical activity, how does it manifest physically, right? Does this random electrical activity start in a place where the motor strip is located? Is it in close proximity? And therefore, do their seizures present with abnormal random movements in certain parts of their body, right? And at this point, what's typically in order, and sometimes what happens is, because we have typically multiple epileptologists that are at the conference, there's typically a discussion and a re-examination of the patient's diagnosis and the efficacy of the treatment they're receiving. There's a word that slipped into the definition purposely of refractory seizure, and that is appropriate seizure medication. And there's oftentimes a discussion as to whether there could be a more appropriate selection of medicine provided for the patients. All of these things are the care that's taken, you can go to the next slide, or the care that's taking place in a way in order to protect patients, to make sure there's a tremendous amount of consideration that goes into the risk associated with putting someone through an epilepsy surgery, even if they are a candidate. Now, the other type of information we can collect, which is a little bit more objective, is the neurophysiological information, right? We'll talk about, how this is affecting a patient's cognition. A seizure that's in the left temporal lobe on a right-hand person, which is likely their dominant hemisphere. Well, does it affect their memory? Well, how do they perform on memory tests, right? Bedside EEG is prominent. And although the patient might have had EEGs in the past, we might do a prolonged EEG study on this patient where we use other techniques like taking them off of their medication, giving them certain stimulus, sleep deprivation, things that we can use to aggravate seizure activity to give us a greater resolution of the seizure patterns, the electrical patterns that occur from the seizures. Next slide. Then we'll go to imaging studies, which are very important for neurosurgeons specifically, right? Neurosurgeons are just glorified anatomists. And what we do is we go inside the body and we rearrange anatomy. So we want to try to get an understanding if there are anatomical anomalies that might be contributing to someone's seizure activities. In this case here, this is a patient we presented at our epilepsy conference yesterday, who has Eric, if you can show them the right temporal lobe, who has a mild, subtle abnormality. The beauty about the brain and human anatomy is that it's symmetrical. So if you see something on one side that you don't see on the other side, it could be a hint or a tell that there's something abnormal there. And this patient is indeed having right temporal lobe seizures. And we have a lesion in the right temporal lobe. Although it's the left side of the picture, it's an MRI, so it's a mirror, it's the right side of the picture. Now, the next thing that we have to do is make sure that that abnormality we find correlates with all the other data that we might be accumulating and acquiring to give us an idea whether that might be the focus, right? The primary focus of this patient's seizures. Next slide. Other imaging studies we might use is something called a MEG study, a magnetoencephalogram, which is a magnet that fits on the head like a helmet. And because the brain communicates with and functions with electrical activity, the changes in electrical activity creates a small magnetic field that can be detected by a sophisticated magnet. Now, we can detect this magnet and then get something else called source imaging, which is essentially an MRI, and we can lay that 3D magnetic information onto that source imaging, and we can try to map out the location of that, that electrical activity to give us additional information as to whether there is abnormal seizure activity that corresponds with the anatomical abnormalities that we've detected on our imaging studies. Next slide. And then another non-invasive study that we can use is a PET scan, which will identify for us metabolism of the brain. And we can indicate areas of hypometabolism or hypermetabolism that might indicate abnormalities. Again, we're taking this data and we're coupling it with all the other data we have, the neurological exam, which allows us to localize, the semiology, which allows us to localize, the EEG data, which allows us to localize. And we're putting all this information because we're looking for confirmation. There's a tremendous amount of care. We're looking for a tremendous amount of confirmation on these patients to give us an indication whether this is the place where the seizures are starting or these are the locations where the seizures are traveling. And do we have an opportunity to either remove the seizure foci or do we have an opportunity to disrupt it? Next slide. And then the last type of study that I want to talk about are ictal studies, ictal meaning seizures, right? A lot of the information we get from patients who are having seizure are interictal, between periods of ictal, where sometimes we have the opportunity to get this anatomical information while someone's having a seizure, right? Rushing them to get a SPECT study where we give a nuclear agent, a radioactive agent to the patient, and we can look at those areas where the uptake is increased and the metabolism is increased because those are the areas that are exhausting a lot of the energy as a result of the seizure activity. Next slide. And this is a picture of the SPECT study. And then next slide. And this is the picture of the other picture before was the MRI spectroscopy study. And then the picture here is a SPECT study. Sounds similar, but different in the sense of the technique used. But what we're getting at now is we're not just looking at the anatomy, but we're looking at the metabolism of the brain and hopefully the metabolism of the brain while a seizure is taking place. Next slide. Lastly, if that's not enough information, we have the ability to then place our monitoring systems right on the surface of the brain by placing subdural grids. And a part of what we're doing when we're getting this information is we're deciding whether it's worth it to put the patient through this risk to get this additional information so we can get more granular information about where the seizure starts and where it travels. Next slide. So we can put in subdural grids or we can put in stereotactic leads inside the substance of the brain so we're not just measuring the surface of the brain. And oftentimes we'll do both to make sure that we're getting enough 3D electrical information to identify where the seizure starts, where they're traveling, and whether there's an opportunity for us to disrupt or remove the seizure activity. Next slide. And what is all of this for? Right? This entire process is for us to sit back and then begin to make decisions based upon the risk of intervening, the risk of not intervening, the benefit of intervening, social factors that involve the patient's individual personalized factors. This is personalized medicine that will go into considering whether we do surgery and expose the patient to the risk of surgery for the benefit of eliminating or reducing their seizures, or whether we don't do surgery. And now I'll hand it off to Dr. Tomich, who's going to specifically talk about some of the surgical techniques we use to treat patients with epilepsy.
Thanks, Lawrence, and thanks, Dr. Segal and Sachdeo. So I'll talk a little bit about surgery itself. Next slide. Next slide. So I'll repeat a little bit of what's been said. Epilepsy is common, and I think the important thing is, as a surgeon who specializes in epilepsies, we're focusing on that 1/3 of patients who do not have a benign self-limited, for example, a Rolandic epilepsy, and who do not have a medically controlled epilepsy, but indeed could be tried on 1, 2, 3, 13 medicines and will continue to have seizures. And that actually, most of our studies show that is about 30 to 40% of the total epilepsy population. So it's not an insignificant group. And why is it important to treat these patients? You know, I look at my job as partly surgery, but partly advocacy. A lot of what I do is try to talk to other physicians who are seeing these patients and talk to them about why it's important. The American Epilepsy Society's motto is aim for zero. Our goal is to get, especially children, but adults as well, to a point where they are having zero seizures, not occasional seizures. Obviously, the higher the burden, the more deleterious it can be, but we want to aim for zero. And that's why for many of these kids with drug-resistant epilepsy, really surgery offers the only chance for prolonged seizure freedom. Next slide. And what I'll submit to you is, while there's no medicines developed in the last 30 years that have really changed this 30 to 40% drug-resistant group, surgery is safe and highly effective, and should really be considered early if you have failed 2 to 3 medicines. What I would also say is a little bit provocative, I think, but I would say that the community caring for patients with epilepsy, and I include myself in that community, I think we've really failed. We failed our patients in a dramatic way. According to the Institute of Medicine, we're operating on less than 1% of appropriate surgical candidates. And that is a tragedy, because if you have a kid with infantile spasms, for example, who might be a surgical candidate, you operate on them early, that kid can go on to have a relatively normal life. If you don't operate on them early, that kid will go on to, develop Lennox-Gastaut phenotype, sometimes be nonverbal, be severely delayed. And so I describe epilepsy surgery as something that not only stops seizures, it saves lives, and it prevents disability. So it's really important. Next. So what is the goal of surgery for epilepsy? Well, when it comes to focal drug-resistant epilepsy, we're looking to characterize, using all these studies that were already discussed, both interictal and ictal studies, to characterize the epileptogenic onset zone. And then in that, surgically, we're going to resect it or disconnect it while we preserve adjacent eloquent tissue. And there's almost always adjacent eloquent tissue, whether that's motor cortex that you can't damage because it'll cause a weakness, or language cortex that you can't damage because it'll cause a language deficit, or visual fibers. And those are the things that we think about the most. Next. So there have been 3 randomized control trials now showing efficacy of surgery for drug-resistant epilepsy. The first one was in 2001, shown here for temporal lobe epilepsy. And again, the number needed to treat, according to this study, to make a patient seizure-free is 2. Now, again, nobody really questions doing a carotid endarterectomy or a carotid stent for high-grade symptomatic carotid stenosis. But the number needed to treat to prevent death or major stroke is 12. I would submit to you that, again, epilepsy surgery is highly effective, but unfortunately continues to be still very underutilized. Next. So there was another follow-up study 12 years later, again, looking at temporal lobe epilepsy. And again, the seizure freedom rates with surgery for temporal lobe epilepsy hover around 70%. And that applies to patients with hippocampal sclerosis, but it also applies to patients with negative MRI and positive PET. Next. And this is the one study, this came out of India, New Delhi, a very good study from a very high volume center. This is the one randomized control trial that specifically looks at pediatric epilepsy and looked at 116 patients. Next. Basically, they were able to do a randomized control study. You can go to the next, thanks. They were able to do a randomized control study because the wait time for surgery at the center was 1 year. So they randomized them to waiting a year or getting immediate surgery. And at 1 year, 77% of the patients in the surgical arm were seizure-free as compared to 7% of the patients in the medical arm. Now, there were some complications, mostly visual field deficits and some increased hemiparesis in the patients who underwent hemispherotomy. Next. Again, here's a Cochrane review looking, this compiled tens of thousands of patients who have gotten epilepsy surgery and showed that the relative risk of being totally seizure-free is 15 at 1 year as compared to patients who do not get surgery. Next. Another criticism of surgery, and it is a valid criticism as well, does continue to be a drop-off. So the longer I've been doing this now, I see patients even at 2 years who sometimes have gone 2 years seizure-free and then have a recurrence in their seizures. And so there does continue to be a curve, but for some types of surgeries, we have very good numbers in terms of the seizure freedom being durable, and that's important. Next. The most common reason I get from referral sources not to do epilepsy surgery is because, again, it's scary. What are the complications? But I'll tell you that in the modern era, this has been looked at carefully. The risk of death or major disability is less than 1%. The risk of minor complications, which can include things like CSF leak and new visual field deficits, could be up to about 5%. But again, largely quite safe. And I would tell you that most of the patients that I give a new quadrant deficit to, for example, temporal lobectomy has about a 15% chance of causing a quadrant nopsia. Most patients don't notice this. And so again, from a quality of life standpoint, very worthwhile to get a new quadrant deficit if you're able to stop seizures. Next. So again, Lawrence already talked about the team. I'll keep going here. There's a big team that makes these decisions and tries to work together. Next. And a number of studies that have been referred to that I won't go into. I'll just say that, we have the ability, thankfully, to do all these studies here in New Jersey. We have one of only about 15 meg scanners in the country in clinical use. So again, we have just about everything we need here to piece together a very comprehensive epilepsy pre-surgical study. Next. And again, I want to talk about this a little bit because, again, I do talk about my job as half advocacy and half surgery. We continue to operate. I would challenge you to find a medical intervention that is less utilized, that is more underutilized than appropriate epilepsy surgery. Certainly, we as surgeons, we don't want to operate on anybody who doesn't need it. We're not interested in operating on somebody with non-epileptic seizures, or somebody with Rolandic or Paniatopoulos type epilepsy, or somebody with a self-limited benign epilepsy. But again, up to 30% of our patients, cortical dysplasia is probably the most common thing that we operate on. Lesional epilepsy with tumors, cortical dysplasia, or post-stroke epilepsy are probably the big three that I see. And these patients are quite numerous. And unfortunately, we're doing a really bad job at identifying them and getting them to surgery. And that's hopefully part of the reason that conferences like this can bring light to this issue. Next. Almost every surgical conference I go to, this is referred to as a national disaster. And it is indeed a national disaster. I think probably it's once a week that I see a patient who says to me, I've had epilepsy for the last 10 years. I've been on 15 different medicines. I've had 4 different neurologists. Why is it this is the first time I'm hearing about epilepsy surgery as an option? And again, this is a very complex, you can go to the next slide, complex issue. We reported on this for epilepsy and tried to understand what are the big factors that lead to this treatment gap. But again, this continues to be a little bit hard to understand, but I think increasingly new generations of physicians are more and more aware of this. And so this is becoming less of an issue as time goes on. Next. We can go to the next slide. And let's skip over the next slide because we're already at 1 p.m. So I'll just show some of the cases that we do. So most surgical epilepsy centers in the country, the most common pediatric surgery epilepsy centers in the country, the most common surgery they're doing is hemispherotomy. And this mirrors our results at Hackensack. This is probably the most common surgery I do. This is a surgical disconnection of a diseased hemisphere. And there are a number of reasons to do this. Patient in the bottom right, I recall this patient well. He was seizing over 200 times a day. When he went to sleep at night, he had a slow spike wave pattern. We call this ESES. And again, he's been seizure free over 2 years with epilepsy surgery. He's beginning to talk. He's beginning to learn better. It's been really life-changing for the family. And so again, this is a powerful surgery. It has, you can go to the next slide. Just some surgical caveats. I always start with something called functional peri-insular hemispherotomy. Lawrence and I have done a number of these now. This is an important surgery for somebody who has hemispheric disease. And not everyone gets weaker after functional hemispherotomy. In fact, about 40% of patients stay the same. About 40% do get a little bit weaker, specifically with pincer grasp. And about 20% of patients actually get stronger on the contralateral side. It's a little hard to imagine, and it'd be hard to believe if I haven't seen it myself. Why do we think this happens? Probably it's in patients who have a very significant seizure burden. There's a degree of encephalopathy that causes motor weakness. And if you can stop the seizures, you actually make them a little bit stronger. I sometimes do unilateral WADA. This has been well described by the Cleveland Clinic. You can't do bilateral WADA in somebody with hemispheric disease. You can do a unilateral WADA, and I sometimes do that if the temporal lobe looks pretty well preserved to make sure that language is not on the affected side. I do these surgeries in Ukraine. We have a project there. There, I always do it without neuronavigation. In this country, I always do it with. Obviously, we have it, and it is useful to make sure that you can functionally disconnect all the parts that you need to disconnect. There was recently a good article called the HOPS score, hemispherotomy outcome prediction score, that talks about who's a candidate, who's not, and how do you do this. Next. But some of the clinical research that we're involved in is trying to come up with algorithms for who is an epilepsy surgical candidate. You know, I tell people, if you go to any ED in the country with chest pain, you get a relatively you get the same treatment. They're going to give you an aspirin to chew. They're going to give you oxygen, morphine. But if you go to 20 different epilepsy centers in the United States with hemispheric epilepsy and hemiparesis, you're actually going to get very different treatment probably. And so we've tried to streamline this and make this almost like an algorithm. Next. Another surgery that we do is posterior quadrant disconnection. I do this for a number of kids with infantile spasms and other etiologies, Lennox-Gastaut as well. This is a disconnection of the posterior quadrant of the brain, which involves temporoparietal and occipital lobes of the brain. Here's a number of kids who got posterior quadrant disconnection, and all of them are seizure-free now. These kids were having multiple daily seizures before. And again, you want to try to do this as young as possible to prevent the neurologic disability that often accompanies infantile spasms. Next. And this is a write-up. We looked at all the posterior quadrant disconnections that were done in the literature. And again, the seizure freedom rate is actually pretty comparable to temporal lobectomy, hovers around 75% for total posterior quadrant disconnection in appropriate candidates. Next. This is a video that we made in a young girl. I sometimes get questions from neurologists and other physicians saying, what does a patient look like after you disconnect the temporoparietal and occipital lobe? And the answer is they usually look about like they did before surgery, with the caveat that they'll have a new visual field deficit if they didn't have that before. But this is a young lady who we did this surgery on, and this was after a failed temporal lobectomy. We had to reoperate on her, but she's now seizure-free for several years. Next. Let's go to the next slide. And then again, I think almost everybody in this country will get operated on with lesional epilepsy. I think the patients that really represent the underutilization problem are patients with normal MRIs. The patients with normal MRIs really require, or the patients who are multifocal, like tuberous sclerosis population. 25 years ago, we didn't operate on tuberous sclerosis almost ever. Since then, Howard Weiner and the group at NYU wrote a paper saying that you can make about half of these kids seizure-free with surgery, and 75% get significant improvement with surgery. So multifocal epilepsy like tuberous sclerosis or the non-lesional cases are probably represent the kids that don't get surgery because they just need so much more work. And that's where I think a multidisciplinary epilepsy conference and clinic comes into play. We get PETs, we get functional MRIs, we can really identify even a normal MRI. Almost all of these kids, almost all the surgeries I'm doing now are 2-stage surgeries. And again, that's where that would come in to place depth electrodes and really delineate seizure onset zones. Next. We can skip through this. Temporal lobe epilepsy used to be a big part of our surgical cohort. Now it's smaller. It's mostly extratemporal surgery, especially in kids. Next. We can go to the next slide. Corpus callosotomy is still a good surgery. It's obviously known to be a good surgery for drop attacks, but actually, you can go to the next slide. This is a review we wrote to talk about that corpus callosotomy is a powerful surgery, not just for drop attacks. It's appropriate for most kids with Lennox-Gastaut syndrome. It can be appropriate for infantile spasms, especially with normal MRI. It can help with a number of different generalized types of epilepsies, not just atonic epilepsies, but rapidly spreading focal seizures. It can help with generalized tonic-clonic seizures, atypical absence seizures. So there's a number of seizure phenotypes that this can help with, and it can be useful not just for therapy, but for diagnostic purposes. So corpus callosotomy is a great idea in a difficult to lateralize bifrontal epilepsy, for example, to figure out which frontal lobe is really responsible for onset. Next. There's a group from Italy recently that talked about posterior selective callosotomy for drop attacks to try to prevent disconnection syndrome. And we've recently done this in New Jersey. And again, this can also be done with a laser, which is great because you don't have to do a craniotomy on these patients. So that's a neat recent, within the last 5 years, innovation in surgery. Next. This just shows how we can place 2 or 3 laser electrodes and target and destroy the corpus callosum. And these other pictures are a laser ablation of the mesial temporal structures, which is the most common reason that we might use laser. Next. Laser is also quite useful in insular epilepsy, and we reported on this. Next. SEEG versus grids. Lawrence showed how subdural grids are placed, but I'll tell you, we're doing this less and less now, obviously. The main reason I place grids now is for language mapping. If this is on the non-dominant side or it's far away from language cortex, we almost always use SEEG. And in the top right picture, you can see these depth electrodes, and that's what they look like. And you can see the planning in the left side of the screen. Next. You don't have to cut the hair. This is done without a craniotomy. So again, we've been doing more and more of these explorations to better delineate seizure onset zone. Also, we do it with a robot now, but you can do it without a robot. And there's a demonstration of that on the right hand using a 3D printed frame. Next. I still think subdural grids has a role, and actually the rate of definitive surgery is higher after subdural grid placement. So might be a little bit better at delineating. Most seizures do come from the cortex, and most of the cortex is on the surface. So it makes sense. Next. VNS is a good therapy, but it's probably used too much in all honesty. And we reported on this. The reason it's used too much is I think, the VNS company, markets for, it can be used for focal, it can be used for generalized epilepsy, Lennox-Gastaut in particular, Dravet syndrome. But, I often get referred VNS when there's a much better choice. And so I think it's important to only do VNS when there's not a curative option. That's the point of this slide. Next. And then RNS has made really, again, I'll tell you that with the advent of thalamic RNS, almost anybody who's failed 2 or 3 medicines, even if they don't have a identifiable focus, could be a surgical candidate. The neat thing about RNS is that you can do it on kids now, you can do it on adults, and we don't know exactly how it works, but it's a neuromodulating therapy, so it seems to change the network of the brain in such a way that improvement in seizures is actually better the longer the RNS has been implanted. So the 7-year results were better than the 5-year results, which were better than the 3-year results. So it'll be interesting to see how this continues to evolve. Next. The last thing I'll say is just, we did 9 epilepsy cases in 2020. You can go to the next slide. We're up to 29 cases the following year, 35 cases the following year, and we're on track to do over 50 this year. So, if we compare our center to centers across the country and in Western Europe, we're now in the upper echelon in terms of surgical volume. So we're proud of that. It's taken a lot of work in the work of everybody in the team, but we now do consider ourselves one of the premier surgical centers in the area. And we hope to continue that work. We're offering now everything, SEEG, RNS. We have intraop MRI at the North Hackensack site. And so again, we're able to offer just about everything. And so we're excited and hoping to continue to grow. Next. You can go to the next slide. I'll stop here, and because I'm sorry we're a bit over, and we can just take whatever questions, and appreciate your time.
Okay, so I want to thank everyone for joining. Thank you, Dr. Daniels, Sachideo, and Tomic, and for all the amazing talks. I also want to thank NJAAP for partnering with us to talk about this really important topic. So I know, like Dr. Tomic said, we're a little bit over, but happy to answer some of the questions that have been coming through.
So we touched on a few of the questions, but I'm just going to throw them out to the group. The first was, are all Lennox-Gastaut patients delayed? Can they receive more help than medication?
Okay, so I could take that question. So as Dr. Sachideo mentioned in his talk, there's a triad. There's a diagnostic criteria for Lennox-Gastaut, and that includes in some type of developmental delay, or if the child's old enough, then it will be considered intellectual disability. So that is part of the clinical criteria. Having said that, in terms of can a child attend mainstream classes or not, there's a spectrum in terms of how significant that disability or delay is. And I think to what Dr. Tomic was saying, the earlier we intervene, the better. I mean, there's been papers out about epilepsy being progressive in many instances, and LGS could fit into that. So the earlier we intervene for more effective therapies, the better. Whether if medications are not working, instead of continuing to cycle through those, to consider some of those non-pharmacologic options. Again, like I discussed in my talk, that can be very effective to try to lift this cognitive fog that the patients may be in because of the heavy seizure burden, and try to get them onto a better path.
Thank you. We had a question from one of our attendees named Charles, and I just want to make sure I'm hitting how he phrased that question, but you can check it out in the Q&A. And he asks sort of a follow-up to a question that you answered. What happens to an area in the brain to cause it to be an eleptogenic focus? I think you answered my question. He said strokes, tumors, and trauma, correct?
I don't know if the surgeons want to take that question.
Yeah, so there are different things that can happen to the brain to make it epileptogenic, which is what I think you're referring to. But the essence of it is this: you have brains that are essentially like or cells that make up the brain's neurons that are essentially like batteries, right? And these batteries are ignited when a certain number of channels on the surface of that battery open up to change the potential, the electrical potential between the outside and the inside of that cell, which then causes the cell to react in a way that sends an electrical signal down a pathway called the axon, right? This is really, really technical. Anything that affects that balance, it could be a chemical imbalance, it could be You know, I say this to people all the time. Anyone who has the brain has the ability to have a seizure, right? You can have a inflammatory reaction adjacent to those cells that might then change the microenvironment near those cells, and it change that electrical capacity, right, by altering those channels. You have some people that have genetic abnormalities in their channels, right, that make their channels more susceptible to fire off under other circumstances when they don't fire off. Some of these things, some of these pathological things, they could be stroke brain, it could be tumor, it could be trauma. I typically explain it to patients that these things irritate the neurons that make them fire off. But in the essence of it, from a microscopic perspective, there are these channels that stabilize essentially the battery of a cell membrane in the neuron. And these channels can be impacted by chemicals that allow then the neurons to shoot and fire when they're not necessarily supposed to. And you get that random activity.
Thank you, Dr. Daniels. So one of the last questions we received was from one of our guests named Amber. She asks, this is more of her personal experience, and it might need some additional private sort of offline one-on-one. But she was asking about her child who's 8 years old, has been on 15 different seizure medicines. Nothing has worked, and he has intractable epilepsy. Right now, it seems that the attendings and residents on that case, don't have answers for why he has seizures, and no medicines will work for all of his tests look normal except for 2 genes of unknown significance. So it may be hard for you to give some weigh in on that, but if you want to share any feedback.
If the EEGs are perfectly normal, MRI is perfectly normal, you need to look at, see what type of seizure is the child having. And is it really seizures or it's something completely different? Because if they are true seizures and they've tried different medicines, first thing I'd like to do is look at the patient's EEG. And if the EEGs are all normal, it's very much possible that it may not be epilepsy.
Yeah, I agree with that. I'm assuming, assuming that maybe what you meant to say, Amber, was that all of the diagnostic tests were normal, but the EEG is abnormal and there are seizures, but we just don't know why. I mean, the way I read that question up until that last sentence was that we have lots of seizures, nothing's working, that we have an abnormal EEG, but we don't have a clear sense of to why the seizures are occurring. I think those are two different questions you're really asking. One is, what is the cause of the child's epilepsy, and the other is, what are we going to do about it? Like Sarah mentioned, I think that maybe is something to discuss in private, depending on what has been done and what the clinical scenario is. But if you have a non-acquired epilepsy, then we dive deep into the genetic testing and the metabolic testing. If we can't find anything else to give us a cause or the etiology. As far as it goes to treatment, I think, like everyone has been saying during this conference, if we are trying multiple medications and we're up into, more than 15 seizure medications and nothing's helping, then I definitely, would consider non-pharmacologic therapies as well, if it has not been thought of. And I listed a lot of those options. And there's a lot of options. And I think it's helpful also for the family to discuss with the team, like, what does success look like? Like, what is the best that we can hope for? And that's, both for the family to answer, and then also for the medical professionals who are working with the family as well to answer, and to sit down with them to try to come up with a path that meets, those needs and those desires.
Great. We have one more question from anonymous attendee, but they mentioned, I am a school nurse and we have many students with VNS. Is there a limit with how many times they can be swiped per seizure? And does it have to be swiped in a certain direction? Some MDs stayed up to down, or right or left.
I'll say something, and I don't know if Dr. Sachade wants to add in. The VNS team, which is the company's called LivaNova, they have their own nurse, and they're pretty good about doing nursing education. I would highly recommend reaching out. They're very accessible, and they can answer all these questions and more. But It can get kind of technical, which is in terms of some of the answer, so it's a little bit outside the scope, but I would totally recommend reaching out to LivaNova, or the patient's neurologist can help make that connection.
And regarding swiping, whether you do up and down, left or right, makes no difference.
Right.
Okay, so that was all the questions we had currently in the Q&A. So thank you so much for everyone who's able to join again on behalf of all of our speakers and on behalf of Hackensack Meridian Children's Health. We were glad to have you, and we look forward to seeing you at our future lunchtime lectures.
Thank you.
Thanks.
Thank you.
Thank you.